Okay, so good morning. We're going to discuss coronary artery disease today. We're going to look, we're going to further elucidate the definition, what is coronary artery disease, look at just overview, normal coronary anatomy. Then we'll go into how these patients present, clinical presentation, the risk factors for coronary artery disease, how you can use echo to make the diagnosis. Then we're going to discuss some additional echo tools to evaluate cardiac performance, the myocardial performance index, MPI, so-called TI index. Then we're going to look at DPDT and then finish up with the mechanical complications of coronary artery disease. So when we talk about coronary artery disease and even peripheral vascular disease, we're talking about the buildup of plaque in the blood vessels around the heart or blood vessels in the lower extremity. And as a result of the building up of the plaques, you get narrowing of the blood vessel, which will result in reduction of the blood flow uh, in the vessel. We have always stressed that the first thing that occur when someone is in the process of developing coronary artery disease is the oxidization of the low density lipoprotein. So it's a type of cholesterol. You know that the cholesterol, you have bad cholesterol, you have good cholesterol. The bad cholesterol is what we call LDL, low density lipoprotein, and then the good cholesterol is HDL, high density lipoprotein. When the initiation of what we call an atherosclerotic plaque is first you get oxidization of the LDL, that's the bad cholesterol. Those oxidized LDL are taken up into the blood vessel wall by specialized cells we call macrophages. So just imagine the LDL circulating in the blood and then they become oxidized. When they become oxidized, it's like you put a coating of sweetening on it. So these macrophages readily take up these LDL. The LDL stick to the wall and then is ingested by macrophages. And those early cells were called foam cells. And then as time goes on, the foam cells gradually get larger and larger, and you have plaques forming. So let's just look at the normal epicardial coronary arteries. You know that you have the aorta, where you have the the sinus, the sinuses in the aorta, sinus of Valsalva. So the left coronary cusp is going to give off the left main coronary artery. The left main coronary artery is going to divide into left anterior descending coronary artery and a left circumflex coronary artery. So this is the blood vessel distribution on the left side. Okay, so the left main comes from the left coronary cusp and then it splits. The left anterior descending coronary artery runs straight down the front of the heart, and the left circumflex loops around the back of the heart. On the right side, from the right coronary cusp, comes up from the sinus of Valsalva, you have the right coronary artery, which loops around the right side. And the right coronary artery divides into what we call PDA, posterior descending coronary artery, and a lateral branch. So this is the rough uh, coronary distribution around the heart. Um, as we had pointed out before, on the back of the heart, the circumflex loops around the back of the heart, okay? And the right coronary artery also goes around the back of the heart where you have the PDA and the lateral uh, branch. Okay. Now, as we were saying before, the normal blood vessel lumen supposed to be nice and smooth. You know, the innermost layer is what we call the endothelium. Then you have the muscle layer, and then outside of that you have the adventitia. So these oxidized LDL, which are attracted to the blood vessel wall, they're engulfed by macrophages. So the macrophages eat up these LDL, and then you get what we call foam cells. And the foam cells gradually build up to give you this plaque. And the plaque is going to obstruct the lumen of the blood vessel and reduce blood flow. You're not going to get reduction in blood flow until the lumen narrowing is 70% or more. Okay, so that is why we usually talk about a significant uh, occlusive lesion being 70% or more, because you're not going to realize reduction in blood flow until the plaque burden is more than 70%. So this is what it looks like in a cross-sectional area. The plaque is there. You have narrowing of the blood vessel lumen. Um, anyway, all right. So how do patients present? What's a clinical presentation of these patients who have blockage? A lot of patients are walking around with blockage and you never know it. Um, they sort of reduce their activity so as not to have any symptoms. Uh, so there are patients walking around with 70% or more blockage, and sometimes you'll pick up these individuals when they come to do an ECG, or they come to do an echo. When they do an echo, if they have multiple blockage, then they will present with reduced ejection fraction, or you might just see wall motion abnormality. The area that blood vessel supply will be hypokinetic or akinetic, depending on what happened before. Or if it's generalized blockages, severe, it can cause a reduction in the ejection fraction. So some of these patients are walking around with ejection fraction 30, 40%. The acute presentation of these patients is what we call myocardial infarction. The other name for that is a heart attack. So this is what we call an acute presentation. What happened here is that the plaque ruptures, the plaque bursts. So showing you the plaque, over time the plaque gradually builds up and the plaque bursts. There are certain criteria that predicts when these plaques will rupture, and a couple of them is if the cap, that is the lining of the plaque, is very thin. So if the lining of the plaque is very thin, it can burst. If the fatty content, of the plaque is very high, then it can also burst. Okay? When these plaque bursts, they release a material in the blood stream that cause what we call platelets to clump on top of the plaque. So the plaque bursts, it releases these gooey material, then the blood clot quickly on top of the plaque, causing acute occlusion or obstruction to the blood vessel. And that's what gives you a heart attack, because you have no blood flow. So the area below the blockage dies. So infarction means death. So the heart muscle dies and you get pain and you can die from that. Whereas angina Angina, when we talk about angina, angina is just chest pain. Chest pain because you have an occlusion. It might not be, it's usually not complete blockage, but a significant blockage that when you exert yourself, you will get chest pain because the area below the blockage is not getting sufficient blood flow. So when you exert yourself, you get chest pain. So, you know, we divide angina into stable angina and unstable angina. Stable angina is, every time you walk, say 10 meters, you get a little discomfort. You stop, it goes away, and you constantly have that stable angina. Whereas unstable angina is, you start getting these chest discomfort with less distance walk or less exertion, or it start come more frequent, or it comes at rest. That's what we call unstable angina. So those patients are very high risk. They're unstable. Uh, Patient can also present with what we call sudden cardiac death, and the reason for that is usually arrhythmia. Uh, these patients are prone to abnormal rhythm because when the heart muscle does not get sufficient blood flow, in addition to chest pain, and when we talk about chest pain, it's not usually the sharp pain that you're accustomed to. A lot of these patients will tell you that they have a tightness, a burning, a squeezing. It's like a elephant sitting on their chest. So that so if you're trying to get a history of chest pain, you may never get it. So you have to ask the right questions. So the sudden cardiac death again is arrhythmic. So when a patient have a heart attack, it's not so much a muscle damage that gonna do them in, is the abnormal rhythm, and the abnormal rhythms that we look that usually cause sudden cardiac death is ventricular tachycardia or ventricular fibrillation. So those are the lethal arrhythmias, okay, and cause sudden cardiac death. Some of these patients, if they're in the hospital, you can quickly uh, abort the event and they'll do very well. Um, Also, significant, as we mentioned before, if you have significant blockage, some of these patients will come to the echo lab and you'll see that they have the ejection fraction is reduced because the heart muscle is not getting sufficient blood supply and nourishment. So, all right. So, what are some of the risk factors that predispose one to coronary artery disease? Age. The older you get, the greater your chance of developing coronary artery disease. Smoking, very potent risk factor. Dyslipidemia, as we talk about the mechanism. So a high LDL, high bad cholesterol, a low HDL, which is the good cholesterol, is also predisposing. Hypertension, diabetes, obesity, and a family history. So these are some of the more common risk factors. Okay, some of them are modifiable, some are not. Age, you can't modify your age. Uh, Family history, you can't really modify that. So, but the other stuff, smoking, uh, dyslipidemia, hypertension, and diabetes, you you can treat them. Diabetes is you know one of the most potent risk factor. So you uh, when you have diabetes, it's a lifestyle change in terms of your diet and taking the medications. Okay, so we can risk stratify these patients, and when we talk about risk stratification, it's basically giving your risk of developing a heart attack. So we commonly do that. Some patients have a very high risk of developing a heart attack, whereas other patients have a low risk of developing a heart attack. And we look at what we call the Framingham score. And with the Framingham score, we take into consideration the patient's age, total cholesterol, the HDL cholesterol, which is the good cholesterol, whether they smoke, yes or no, the systolic blood pressure, and if they're diabetic. So we look at all these and we put them uh, in a risk table, and then we can give the patient, a 10-year risk of developing a heart attack. Now, how do we use the echo to make the diagnosis of coronary artery disease? And as mentioned before, if you have significant blockage of the blood vessel supplying a particular segment, then the first thing that's going to happen, well, after a series of events, the first thing that's going to happen, you get wall motion abnormality. So again, when you look at a segment, you're looking for thickening. You're looking for thickening and motion to some extent. Uh, when we did look at strain and strain rate, we we pointed out that some area that is hypokinetic, not getting sufficient blood flow, may look normal because it's pulled, or you get what we call the feathering effect. It's pulled by the normal segment. So it gives the appearance that it's normal. But if you do strain and strain rate analysis, you'll see that it's abnormal. So in addition to just looking at wall motion abnormality, you can do strain assessment and determine that that segment is abnormal. If you have multiple blockage of the blood vessel around the heart, it can affect the contractility of the heart. And when you do your ejection fraction analysis, you see that your ejection fraction is depressed. So a lot of patients come to the echo lab not suspecting anything because they may, come for clearance for surgery or for chemotherapy. And then you find that they have an ejection fraction 30, 40%. And then further analysis, you find that they have coronary artery disease. But patients may have a normal ejection fraction. The wall motion and everything may look normal. So these patients, when you stress them, you can bring out the abnormality because they may be walking around with a 70% occlusion, but because they're not exerting themselves, the muscle below the blockage is getting sufficient blood flow at rest. But once you stress the heart, they walk them on the treadmill. That area now, which requires more blood flow, cannot get the increase in blood flow. So it manifests itself with what we call wall motion abnormality. You may get hypokinesis, akinesis, or dyskinesis. Um, some of these patients may present with diastolic dysfunction, and this is a relatively new area that we're looking into because at rest, patients may have normal wall motion abnormality, normal wall motion. When we look at our or EE prime, remember EE prime gives you information about left ventricle filling pressure. If these patients have coronary artery disease, uh, when they exert themselves, then you'll see the wall motion. You might not see the wall motion abnormality, but the left ventricle end diastolic pressure goes up because there's abnormal relaxation of the heart muscle, and that's going to send the left ventricle filling pressures up. So one way to assess these patients, especially if someone comes to you and tell you that they have exertional shortness of breath when they exert themselves, and you do all the other tests There's no lung disease. Everything is fine. You can do, this is what we call a diastolic stress test. So when you do your evaluation at rest, they may have a normal ejection fraction, your EE prime, which gonna tell you about LV filling pressures, may be normal. That may be 10. So, again, a EE prime using the medial EE prime above 15 suggests that there is increase in LV filling pressures. But they may be normal at rest. So you might have to exert these patients, put them on do a stress test, and then you evaluate the EE prime after the stress test, and it may move from say 10 to 25, telling you that when these patients exert themselves, they get increase in filling pressures, left ventricular filling pressures, and that is why they're symptomatic with shortness of breath. Remember that when you have coronary artery disease blockage, if the blockage is significant, then you'll get diastolic dysfunction, because these patients can develop abnormal relaxation. And so when you do when you exercise them and you look at the EE prime, it will be elevated, telling you that they have increased left ventricular filling pressures, which will cause symptoms. So it's important. So this is you can see, this, if this patient comes to the echo lab, you can see that there is wall motion abnormality. Ejection fraction is reduced. Okay? Just looking at it, you have seen enough hearts to know that this is not contracting properly. So, and a very common presentation as well is mitral regurgitation. So in addition to the wall motion abnormality, these patients will have mitral regurgitation. So if you look at this, the whole apex look akinetic. The the basal and mid septum is somewhat hypokinetic. The lateral wall is somewhat hypokinetic. So overall ejection fraction is probably 30%. So you have to look at the different segments, however, and determine if that segment is hypokinetic or akinetic. Okay, and then depending on the segment that is involved, you can determine the blood vessel that is occluded, the blood vessel that blocked. So you're also going to do your Doppler assessment. Okay, again, if you know, it's important to. So this is our two-chamber view. You can see that the apex again is akinetic, inferior wall is somewhat hypo, the anterior wall is hypo. So this patient more than likely have multi-vessel disease because it cuts across all areas. So um, it's important to determine the segment that is abnormal, because if you can accurately determine the segment that's involved, you can predict the blood vessel that's occluded. So when I take that patient to the catheterization lab, I suspecting that it's going to be a LAD blockage or a RCA blockage. So the echo is very important in helping you to plan treatment for these patients. So we will do stress tests if the presentation is not diagnostic. Say, if the patient comes with typical chest pain, tightness, pressure, burning when they exert themselves goes away when they're relaxing, and then I look at the ECG. The ECG suggests that there are some blockages with T wave changes. The echo is also supportive. I'm not going to do a stress test on that patient. I take the patient straight to the cath lab and do a cardiac cath and then put a stent in. But if the patient presents with chest pain, which is not very classic, there's no EKG changes, no echo change, sorry, no baseline echo change, then I want to do a stress test. And one of the stress tests we can do is a stress echo. Okay. Um, when we do stress echo, we have to exercise the patient, or we can do a chemical stress test using dobutamine. We just want to get the heart rate up, and we can exercise the patient to get the heart rate up. We can use a treadmill. Most commonly in the Western world, we use treadmill, but you can use a bicycle, what we call a supine bicycle. The patient lies on their back and they're hold on to something and they're pedaling the bike. So supine bicycle, or if the patient cannot exercise for whatever reason, you do a chemical stress test. We use dobutamine. Dobutamine is going to increase the heart rate, and we do the test. Again, if you know the segment that is abnormal, you can predict which blood vessel is occluded. We did this before, but we're just going to go over it again. So, shaded in gray is the LAD territory. So, when you look at the apex, the anterior wall and the septum in the apex is usually supplied by the LAD. When you look at the short axis, the mid cavitary level, okay, the RCA, which is the shaded, the gray shaded lines, the RCA territory with your short axis, the mid cavitary level, is your inferior and your inferior wall and the inferior septum. Okay, so and then in the apex is the direct inferior for the RCA. Okay, the circumflex is the unshaded area. So in your when the apical segment, the lateral wall is supplied by the left circumflex. Remember, we said the circumflex, when the left main, which comes from the left coronary sinus, splits and give you a left anterior descending coronary artery, which runs in the front, and the circumflex loops around the back. So in the apical segment, it supplies the lateral wall. In the mid segment, it supplies the anterior lateral and the inferior lateral wall, still the lateral wall. And then the basal segment, the same thing, lateral wall. If you were to look at your parasternal long axis, then the circumflex will supply the septum, your basal and mid septum, and the posterior wall. So these are rough distribution of the coronary artery. So by looking at the segment that's involved, you can accurately predict the blood vessel that's occluded. So when we do a stress test, so when we do a stress echo, we do we get a resting 2D echocardiogram. So we get a resting 2D echocardiogram, and then we put the patient on the treadmill, or we give them the dobutamine, and then we're gonna get exercise or stress images. Okay, so we're gonna get exercise or stress imaging. So let's just concentrate on our exercise stress echo, not the dobutamine. We'll go over that separate. So if you're doing a regular stress echo and there's no wall motion abnormality at rest, when you exercise the patient and then you take the patient off the treadmill and you do your echo at just after the patient exercise, you're supposed to get an increase in the ejection fraction. Okay, the wall is supposed to be moving faster, and it's supposed to thicken a little bit more. So we talk about a hyperdynamic response. So this is normal. So normal echo at rest, no wall motion abnormality. Hyperdynamic after exercise, it's a normal study. If the resting echo is normal, and then when you do your stress and then you repeat your echo, if you see any wall motion abnormality, it's usually due to ischemia. Remember, when you increase the demand on the heart and it cannot increase the blood flow to that area, that muscle, then the muscle is not going to move properly. So once you get any wall motion abnormality with stress, then that's what we call ischemia. If you do your resting echo and you start with wall motion abnormality, and then when you do your stress echo, if the wall motion abnormality get worse. Say you look at a particular segment and it was hypokinetic. When you do your stress, if it's now akinetic, then that's also ischemia. Okay? If you have wall motion abnormality at rest, okay, and it's unchanged at when you do your stress and you repeat your echo, then it suggests infarct. So remember, infarct is dead muscle. So the dead muscle, if it's dead at rest and you exert the patient, because the muscle is dead, it's not going to do anything. It's not going to thicken. You may get some movement because of tethering, but it's not going to thicken. Dead muscle do not thicken. So if you have abnormality at rest with stress is unchanged, that's what we call infarction. Or if you have what we call an akinetic segment, no thickening at all at rest, and then with after the stress and you do your echo, if it's dyskinetic, then that's also infarction. Okay? When we say dyskinetic, the normal thing for the heart when it contracts is to come together. When it's dyskinetic, instead of coming together, it bulges, it goes the opposite direction. Okay? All right. Now, this is the scenario for dobutamine. When you do dobutamine, we, as opposed to your exercise stress echo, where you have just two phase, your resting and your stress. When you do dobutamine, you have multiple phase. You have your resting, your low dose, your peak, and recovery. Um, and you're going to gradually increase the dose of the dobutamine, and you're going to get your echo image at rest. You're going to get a low dose echo image, a peak echo image, and an echo image at recovery. So if you do your dobutamine stress echo and at rest everything looks normal, low dose the ejection fraction increase a little bit. At peak it increased a lot, and then at recovery the ejection fraction reduce a little bit. That's a normal response. Okay, so a normal response to dobutamine, it's going to increase the heart rate, it's going to increase contractility. Okay, so at rest if it's normal, low dose is going to be the ejection fraction is going to increase a little bit. At peak dose it's going to increase quite a bit, and with recovery it's going to reduce back to where it was. So that's a normal response. However, we can use dobutamine stress echo to evaluate what we call viability. So someone comes to the echo lab with an ejection fraction of say 30%. Come to the echo lab, ejection fraction 30%. because of blockage. Now, some of that muscle in the heart is going to be dead. Some of that muscle is going to be dead. If you plan to do an intervention on this patient, say you want to put a stent in or you want to do bypass surgery, you don't want to do you don't want to put a stent in or do bypass surgery if the muscle is dead, because you're going to introduce the patient to increased risk and they're not going to get the benefit. So we do what we call viability study. Viability study. That is, we try to determine if there's viable muscle in the heart. That is there living muscle? So when we intervene, whether by putting in a stent or doing bypass surgery and increase the blood flow, then because the muscle now start getting increased blood flow, the function uh, comes back to normal. So you have to do a test to determine if there's viable muscle, because if all that 30% is just dead muscle, you just treat the patient medically. You do not increase the patient risk because they're not going to benefit from you doing anything. And not only that, you might hurt them. Okay. So we do viability study. And how we use dobutamine for that viability study is, say at rest, the ejection fraction is 30%. We don't know if there is viable muscle in some of the in the muscle. But when we do our echo at rest, we get an injection fraction of 30%. With our low dose dobutamine, it's gonna increase the blood flow. The demand, the muscle demand is not tremendous, but by increasing the blood flow, if they're viable muscle, you're going to see that the ejection fraction increase. So instead of say 30% at low dose dobutamine, the ejection fraction may increase to 50%. When you continue to your peak dose dobutamine, then because now the demand is very high and you have a blockage which cannot keep up with the demand, then you're going to bring out the wall motion abnormality again. So the ejection fraction may fall to 30%. Or when you look at in an individual segment, you're going to see that the segment is now hypokinetic or akinetic. Okay? And then in recovery, it sort of get back to baseline. So that is what we call a biphasic response. So a biphasic response is you have abnormality at rest. Say ejection fraction. Say you look at a particular segment, and the segment is say hypokinetic. With your low dose dobutamine, that segment now looks normal because it's getting increased blood flow with your low dose dobutamine, and it start uh, contract normal. It thickens normal. But as you increase the dose of your dobutamine and the demand increase, then it goes back to being hypokinetic or akinetic and then recover. So that's what we call a biphasic response. So if you get a biphasic response with your dobutamine, it suggests that there's viable muscle, because if the muscle start behave normal with low dose dobutamine, it could only mean that some of the muscle is alive. Dead muscle do not thicken. So you have to assume that some of the muscle is viable. And so if you were to do a stent or bypass surgery, those patients would benefit. So it is customary for patients with low ejection fraction, if you plan to intervene in these patients, whether putting in a stent or bypass surgery, you need to do a viability study, and you can use dobutamine for that. We also use we do nuclear stress tests using thallium as well. But since we're doing echo, dobutamine. Okay, so the last scenario is you have wall motion abnormality at rest. So patient come to the echo lab and resting to the echo shows ejection fraction 30%, and you do your stress test, and that 30%, after you stress them and you repeat your echo, ejection fraction 50%, it suggests that they have a cardiomyopathy, a non-ischemic cardiomyopathy, viral, drug induced, whatever. So they're abnormal at rest, but when you stress them, it improves. That's a cardiomyopathy. So these are the various scenarios, and this when you so these are the condition, the resting and stress, and then the interpretation that you can make. And usually, when you do any exam, they will give you the resting and stress and ask you what's the interpretation there. So you need to go over this, try and understand it fully. Okay. Now, the tie index, we did it when when we look at the right side of the heart. So the myocardial performance index. Um, we can do it on the left side as well. It's also called the tie index. Uh, what we do, so when we do MPI, we look at the overall. It's an assessment of the overall myocardial function. So we're looking at both systolic and diastolic function. Okay. So the MPI look at the overall function of the heart. We use P doubler. The other, when we did for the right side, we talk about RIMP. So it's LIMP for the left side, left ventricular index of myocardial performance. So RIMP for the right side, LIMP for the left side. Okay, it's a P doubler measurement. Uh, or sample volume is at the tip of the mitral leaflet, and we do it in the four chamber view. So if you remember what we did when we did RIMP, is the same thing. It is from it's an interval, so it's a time duration. It's from mitral valve closing to mitral valve opening minus the ejection time divided by the ejection time. Okay, it is the definition is from mitral valve closing to mitral valve opening minus ejection time over ejection time. So your sample volume is at the left ventricular flow track. So to get the mitral valve closing to mitral valve opening, your sample volume is at the tip of the mitral leaflet. To get the ejection time, your sample volume should be at the left ventricular flow track. Okay, and this is what this is what you end up with. Okay, so the definition for left ventricular index of myocardial performance, also called the tie index, it is the duration from the mitral valve closure to the mitral valve opening. So this duration, you're going to subtract the ejection time from it, and it's divided by the ejection time. When we look at the Doppler, you're going to see that mitral valve closure to mitral valve opening minus ejection time is just IVCT, isovolumic contraction time, plus IVRT divided by ejection time. And this is what you do. So, this is your mitral inflow, your E and your A. Mitral valve close right there, mitral valve open right there, mitral valve close. So we say it is the mitral valve closure to the mitral valve opening. This duration, you're going to subtract from that the ejection time. So if you just remember, so the ejection time, so to get the mitral valve opening, the mitral valve closure, mitral valve opening, sample volume is at the tip of the mitral leaflet. To get the ejection time, you know, uh, your left ventricular flow tract envelope. So you put your sample volume, left ventricular flow tract. So you're going to get these Dopplers thing. So definition is mitral valve closure to mitral valve opening. You're going to subtract the ejection time. When you subtract the ejection time, you can see that from mitral valve closure from mitral valve closure to ejection, that's what we call the IVCT, isovolumic contraction time. From the end of the ejection to where the mitral valve opens is the IVRT. So that is why when you subtract the ejection time from this time up here, you're left with IVCT plus IVRT. And then you just divide it by the ejection time. And that is LIMP, left ventricular index of myocardial performance. It gives you overall evaluation of myocardial function, both systolic and diastolic. Okay, so the normal value is about 0.39 plus or minus 0.05. Your LIMP is going to increase in patient with all spectrum of heart disease. So once you have any type of a heart defect, it's going to increase. And we spoke about RIMP before. You know, it's usually a research tool we use in patients with pulmonary hypertension. The other method to evaluate contractility of the heart is looking at what we call DPDT, change in pressure with time. DPDT, change in pressure with time. So if you just conceptualize, if you have a normal left ventricle, a strong left ventricle, the ventricle is gonna contract vigorously. We need mitral regurgitation to evaluate this phenomenon. And that is because if you have a strong muscle, it's going to pump the blood from the LV to the left atrium in a short period of time because it's a strong muscle. So if you have mitral regurgitation and the muscle is strong, it's in a short period of time it's going to pump the blood from the left ventricle into the left atrium. If the muscle is weak, however, it's going to take a much longer time to pump the blood from the left ventricle into the left atrium. So that in a nutshell is DPDT, change in pressure with respect to time. So DPDT assesses the global LV contractility. So it's not looking at segments, it's the overall contractility of the left ventricle. Okay, so the pressure generated in the LV during the isovolumic contraction time. Okay, so it is the pressure that's generated in that period of time. And again, we use mitral regurgitation jet to evaluate this. The sweep speed should be great, so 100 or greater. So 100 millimeter per second or greater. So you have to adjust your sweep speed. We use CW because it's mitral regurgitation, and we adjust the velocity to about 4 meters per second. Okay, so it's a change in pressure with respect to time. So what you're going to do, we use 1 meter and 3 meter per second. So these are velocities, okay? So we use 1 meter and 3 meter per second velocities. And I'm going to show it to you, but I'm just giving you the mathematics right here. So at 1 meter per second, you calculate the gradient. Gradient is equal to 4v squared. At 3 meters per second, you also calculate the gradient, and you find the difference. Okay. Basically, what you're doing, you're looking at the time it takes to generate this pressure in the LV. Again, a strong muscle is going to take a short time to generate pressure between 1 and 3 meters per second. So a strong muscle, the time is going to be very short. So when you do your DPDT, remember you're dividing by time. So if the time is short with a strong muscle, you expect this number to be greater when the muscle is normal. Okay, so we use the 1 meter and 3 meter per second velocity. We get the gradient or the pressure at 1 meter per second. So for v squared, velocity is 1. At 3 meters, velocity is 3. Square root 3 multiplied by 4. So it's basically the pressure gradient between 1 and 3 meters per second using the modified Bernoulli equation. So again, the velocities is 1 and 3 meters. So at 3 meters, the gradient is 4 times 3 squared. 1 meter is 4 times 1 squared. The difference is 32. This is not 42. So the difference is 32 millimeters mercury, not hertz, millimeter mercury. Okay, 32. So dPdt, so that's what we did. On the following on the previous page was looking at the change in pressure. dP is change in pressure. Change in time, the machine will give you that. The machine will give you that. So again, a strong muscle is going to take a very short time to eject the blood from the LV into the left atrium. So your dPdt is going to be greater for a strong muscle. A weak muscle going to take a longer time. So your dPdt is going to be a smaller number. Okay, so your change in time is the time it takes to generate this pressure. So a strong muscle is going to generate this pressure in a short time. Weak muscle is going to take a longer time. So normal values for dPdt is about 1200 millimeters mercury per second. It's going to be much smaller for weak muscle. So this is how you do it. Okay? So let's use the Doppler. So again, your apical four-chamber view, you use C Doppler. Your sweep speed should be adjusted, and you get your mitral regurgitation. Okay, mitral regurgitation is systolic flow, so you get it. You adjust your thing to about 4 meters per second. So at 1 meter, so you can see, so on the vertical axis is velocity, on the horizontal axis is time. So what you do at 1 meter, so 1 meter is right there, you come across, and where you get to your Doppler, that is your time. That's where you're going to start the time from. So you just come up right there. Okay, that's where you're going. So you come straight up to the time axis, and you get your time. At 3 meters per second, then you do the same thing. Okay, at 3 meters per second, you do the same thing. So it's about right here. You come where it intersect, then you come up, and then you get the time. This time difference is the time it's going to take to generate that pressure between 1 meter per second and 3 meters per second. Okay, the machine will do it for you though, but basically, you know, you have to. So again, on the vertical axis is your velocity. You can see that it's so. It's, I think this is 6 here, so that will be 2, 4. No, what is this? Um, so it is, each of them is I think 1. But anyway, so at 1 meter per second, you come across where it intersects your envelope, you go up. That's your initial time. At 3 meters per second, you come across where it intersects the Doppler, you come up, and that's the change in time. That's a change in time. So you can do it manually, okay? You know, the change in pressure is 32, and the change in time, you know, you can measure it, or you know, the computer give it to you. So you divide 32 by you have to change a unit though. You have to change this to seconds. Okay. So on the cartoon shows it over here. You have mitral regurgitation. This is your mitral regurgitation envelope. Okay. Velocities on the vertical axis. It comes straight across at 1 meter per second. You come straight across where it intersect the envelope. You go up, and that is your initial time. 3 meters per second. You come where it intersect. You go up, and you get the time it takes for 3 meters per second. This time interval is a change in time. Okay. Again, what we're doing, we're seeing how strong the muscle is. If the muscle is strong, it should pump that mitral regurgitation out in a very short period of time. If it's weak, it's going to take a longer time. A normal value should be above 1200 millimeters mercury per second. Okay. Um, so we on the right side, I think we did this for the right side. Instead of 1 and 3 for the right side, you use 1 meter and 2 meters. So the change in pressure is going to be only 12. So um, let's the mechanical complications of we're going to leave that, and then we'll do it with when we do stress tests in detail. We'll do mechanical complications and stress tests together.